and then I will start recording after that, a few minutes before we actually formally starts. But I think it's so good to see all of you here. uh, मुझे नहीं याद पड़ता कि हमने पीडियाट्रिक्स पे पहले कोई प्रोग्राम किया हो, और हमने बहुत से ग्रुप्स और सब स्पेशलिटीज शुरू की हैं अपना मेरिट में, मैंने और शाहिद ने. I should close my YouTube. Sorry about that. So I think one of the subspecialty, really important one that we have been missing is pediatrics. So it will be so good to provide this education to physicians. Um, ये live webinar है, but a lot of our audience actually watch the recorded sessions later. So typically we have about 30 to 50 live audience from Pakistan and 20 to 30 from US. So anywhere from 50 to 70 people join the webinar on most days. But then we also feed this live to Facebook or YouTube, and we get another 100 to 200 views on YouTube. And then recorded sessions over the month will probably have about 5 to 700 views. And then what we have been doing is that we have been partnering with some collaborators in Pakistan to spread this information. So we have partnered with industry. There is the third largest pharmaceutical in Pakistan, Farm Evo, that we partner with, who send it to their physician people that are in their network, which is about 3,000 physicians. And now we have recently partnered with government of Pakistan's project called Yarane Watan, where they are basically sending out this webinar flyer to all the government facilities, so all the COVID units and all the COVID designated hospitals, federal hospitals, DHUs, and things like that, district hospitals, and and they will have a recorded session posted on their website too. So I think the information will spread easily to about 1,000 or more people. It will be useful for many of them. So we still have a minute before I want to start. So any questions from anyone? I went over a little bit that we will keep the format very simple. I will just introduce some house rules to the audience and for the recording before I invite the speaker to introduce herself. And then the speaker can start with the basic presentation and take a half hour or so, and then we will go around and have the panelists introduce themselves before we open the Q&A. And Shahid Bhai, those of you who don't know, is the chair of APPNA MERIT committee, which is focused on doing medical education and skill transfer to Pakistan. And what we're trying to do is to create as many working groups and subspecialties as we can. So we have working group, Dr. Kamani is here, who's leading our effort in critical care medicine as well as nursing in Pakistan. We have a group on psychiatry, group on dermatology, we have group on neurology, we have group in nephrology, infectious disease, and each of us are working on various projects. So we develop online courses in addition to these webinars, which are like certificate courses or skill-based courses. And then we probably would in future be doing we typically try to do a large winter meeting in Pakistan with speakers for local institutions. And we're also working, Shahid is leading a huge effort on developing programs in family medicine in Pakistan. And I think pediatrics will be a very important part of that family medicine development in Pakistan. Shahid, you want to say anything?
Thank you everyone to join. It's basically a teamwork, really. Me and Danish are providing some support and infrastructure, and with Waleed, who is in Pakistan, he's doing a tremendous job. Recently, we have really increased our activities, and that's why the work is more, and we need more man hours, people, Waleed's time, and we are starting to raise funds also for all these projects recently. But it's really how much more we can do. There's no limit because there are so many disciplines within the medical field, and then pediatrics. If you talk about that, there's a mirror image. In pediatrics, there are further, and we have some child psychiatrists here today. So specialties, and even yesterday we talked about to a professor of sociology. So there's no limit to what we can do for healthcare and medical education in Pakistan. It's really the how much more involved APPNA membership will be, and physicians in general will be to do their part. So we welcome everyone to these efforts, and let us know any way we can help. Thank you, Dan.
Very good. So I think I will get started formally. And I just want to say that if you have, try to stay muted if you're not speaking, and then you can unmute yourself when you're speaking. And if you have two devices, sometime it can create a feedback and echo if you, both of them have their speaker on or microphone on. Um, Very good. So, welcome everyone. I am Danish Bhatti. I'm the movement disorder neurologist at University of Nebraska Medical Center, and I am also the co-chair for APPNA MERIT, the APPNA's Committee on Medical Education. Welcome to our weekly MERIT COVID webinars to talk about struggles with the COVID infections and lessons learned from clinical cases. Um, I know that we are starting a little late because of our technical challenges with Zoom, and I think people are still behind, and they will keep gradually coming in, but we should get started for everyone's time who's here. um, I'm really delighted to have this unique experience today on pediatric patients and role issues in kids, something that we have so far not discussed properly throughout the discussions on COVID. And, I guess very early on, we said kids have very low risk of infection and very low risk of problem. We just then ignored that afterwards and started worrying about the really, really old and elderly people. But I think we need to learn and understand how kids are being affected by COVID and what issues or challenges they're having. So we have a really, really good group of people, experts, speakers, and panelists here to discuss that. And I think this will be very useful and very learning opportunity for me too. So house rules, remember that we will start with introduction from the speaker and a talk for about half hour or so. And that will be followed by introduction and comments from the panelists before we open it up for the Q&A. Please introduce yourself in the chat box, whether you are an attendee or a participant from US or Pakistan. And then please use the Q&A box to put your questions in. You could also use the chat feature, but it's easier to track the questions in the Q&A box. So I will encourage you to do that. And then if you would like to speak or have the microphone, please raise your hand and I will try to get to you if the time allows, to give you the microphone and an ability to make your comments verbally or ask your questions. So with that, let me begin with the day by inviting our speaker to introduce herself and then share her screen for presentation. So Dr. Mehreen Arshad, please go ahead.
Hey, assalamu alaikum, everyone. I'm Mehreen Arshad. I'm a pediatric infectious disease physician at Lurie Children's Hospital in Northwestern University in Chicago. So let me just share my screen. And so while I'm doing that, this topic my current presentation is on the post-infection inflammatory syndrome that has been recently described in children. But I think I'll just, since it sounds like we don't talk about children a lot, I'll just take a few minutes to talk about COVID in pediatric population in general. So, children, I think, have sort of been overlooked in this pandemic, even in the US, where we don't think about children as much because they don't get as sick and, et cetera. But children certainly get infected with COVID. In our hospital, we are a freestanding children's hospital in Chicago, so obviously a big city, but we have had 600 children go through our system, our healthcare system, who have been positive. Yes, very few of them have ended up requiring hospitalization, and even fewer have required have required, and ICU level care. However, this is certainly a disease that spreads among children. It spreads, we know that it spreads from adults to children. I think the data on children to adult transmission is, is perhaps sort of out there right now, and maybe children don't transmit as well as well to adults compared to adults to children. But I think, as schools are opening across the US certainly, and I know across the world, I think that we just need to be very careful about keeping an eye on the number of infections in kids, because even if let's say hospitalization rates are like 5% of all children, if you have millions of children going to school and lots of children getting infected, and that translates to a lot of pediatric patients requiring inpatient care. And so I'll start with that. And then COVID is, and so in addition to sort of, COVID and being a disease in children, we've also now recently, within the last, month or 6 weeks or so, I would say we've now realized that there's another sort of post-inflammatory syndrome that is also now being described, particularly in children. So this is MIS-C, or it stands for multi-inflammatory syndrome in children. So this is, as the name says, this is particular to children. And the reason, and so this is just an overview of the inflammatory response to the virus, to the SARS-CoV virus. So as you can see, in mild disease, we think that the viral load, goes up and comes down pretty quickly, and the inflammatory response is also, there's less inflammation, so you have less of an IL-6 response, less of, perhaps there is some data coming out that perhaps your the antibody response is also lower, but then you also have, less of an interferon gamma response. In children who have MIS-C or who have more severe disease, the thought is that the viral load basically lasts for a longer time, and there is this delayed inflammatory response. And because of the delayed inflammatory response, you have this post-infection inflammatory response that we see up to about 4 weeks after the initial infection. So if you look at the case definition, this is according to the CDC guidelines, and are in line with what has been what has been proposed by the European Union as well. So the case definition is anyone who's less than 21 years of age who presents with fever and lab evidence of inflammation. We'll get to that in a second, and has evidence of clinically severe illness that requires hospitalization with multisystems. You have to have more than 2 organ system involvement, and those organ system could be cardiac, renal, respiratory, hematologic, GI, dermatologic, or neurologic, and there should be no alternative plausible diagnosis, and they should either be currently or recently positive for SARS-CoV-2, for the virus by RT-PCR, they should, or serology or antigen test, or they should have a known exposure to someone who was COVID positive within 4 weeks prior to the onset of symptoms. So in terms of fever, the patient should have had fever for greater than 38 degrees Celsius for more than 24 hours, or at least report of subjective fever that has lasted for more than 24 hours. And then they should also include, but not limit, and the blood test should include CRP, so it's a C-reactive protein, elevated ESR, fibrinogen, procalcitonin, D-dimer, ferritin, lactic acid, dehydrogenase, IL-6, and then elevated neutrophils and reduced lymphocytes and low albumin. Now, I will say in our practice, we don't test all of these. We tend to test the CRP and D-dimer and ferritin more commonly, as well as the IL-6. But these are all the inflammatory markers that CDC says that if any of them, if one or more of them are elevated, then that is an indication for MIS-C. And some of these MIS-C, the earlier reports of MIS-C, there was a lot of sort of confusion about Kawasaki's disease. So if you remember, Kawasaki's disease is again a particularly, it's an inflammatory condition which we think is post-viral, but we're not exactly sure which virus, that happens in children. Generally, it's younger children between the ages of from babies to like 5 years of age. So usually they're preschool children. Or early elementary school, and the initial description of this disease of MIS-C was somewhat in line with Kawasaki's, and so I think there was a you may have heard that in Europe, and this was first described in Italy and in UK, that there were a lot more kids who were getting Kawasaki's disease. I think since then we've now realized that this is probably MIS-C is probably a separate entity compared to Kawasaki's disease, and there are some overlapping features, and in fact treatment may in some cases also be overlapping, but it does seem to be MIS-C does seem to have some specific specific features that are associated with it that are not present in Kawasaki's as frequently. And then they also, so CDC also recommends that, we should consider MIS-C in any pediatric death with evidence of SARS-CoV-2. So like I said, SARS, the COVID disease itself is it's common in children, but the severity of it is much less in children, and so we've had very few deaths in the pediatric population associated with the COVID disease in itself. And so I think there, the thought now is that perhaps the death that does in kids that do die, there may be a component of MIS-C in them as well. So New York, and in the US, New York has seen the most MIS-C cases. And so we've been following their sort of lead, in this country. And the reason is because, as you may know, New York had a lot of COVID cases. And so obviously, when the prevalence in the community and incidence in the community is high, so obviously even the children are going to get infected, and so they've seen a lot of MIS-C. The symptoms that they've reported most commonly in children, one is that these kids tend to have fever for many days, and the most common symptoms are GI symptoms that can include either abdominal pain, nausea, vomiting, diarrhea, and then rash that is generally whole body rash, and it can be anywhere from it can look like urticaria, it can look like erythema multiforme, so different types of rash, and then conjunctivitis, so red eyes, then the lips become red and swollen, and these kids can also have headaches and shock. So they literally basically have changes in perfusion, hypotension, so they look like they're in some sort of septic shock. The less common symptoms that they reported were skin peeling, and then neurologic signs such as lethargy, focal deficit. So you have decreased sensation in one place, or decreased movement in one limb, and then seizures. You can also have myalgias, respiratory symptoms, and lymphadenopathy, so swollen lymph nodes. So you can see, those of you who may have seen Kawasaki's disease, there are certainly some of these features that are also overlapping with Kawasaki's, but in Kawasaki's, GI symptoms are not that common. For example, headaches can occur, but again, not so common. Neurologic abnormalities are not that common. So there are some symptoms, some features that are specific to MIS-C. And then when you look at the lab assessment, nearly all of these patients will have elevated inflammatory markers, most commonly the ones that are tested as CRP and ESR. They also, most of them will also have an elevated cardiac marker. So they might have an elevated troponin or the proBNP. So, and then the CBCs, the complete blood count may demonstrate low platelets and decreased lymphocytes. So that is, that is something I think that's been seen pretty commonly in COVID as well. So there's certainly some overlap with the disease. when you look at the the cardiovascular findings in COVID, if you look at echoes in patients who have MIS-C, 85% of them have normal function, and 70% of them have normal coronary arteries. But that means that 30% of them can actually have aneurysms or dilation in their coronary arteries as well, and then 15% of them have decreased cardiac function. In very rare occurrences, there have been some patients with some aneurysms, but in their experience, the New York experience, they usually resolve with treatment. When we look at do a little bit of deeper dive in the New York experience, most of the patients when they presented, they had or I would say half of the patients were positive for the SARS-CoV-2 on RT-PCR, and about but most of them, or almost all of them, had positive IgG on serologic assays, and that doesn't really change all that much if you look at the different age groups. When you look at the symptoms according to the different age groups, so the darker over in this figure, the darker cell means that it's more common in that age group. So dermatologic or mucocutaneous lesions or findings are more common in the younger age group, and so are the some of the more common KD symptoms, because like I said, KD symptoms, KD tends to occur in children that are in the younger age group. And then if you look at the older age groups, the GI symptoms tend to be much more common in the older age group, and so and as well as the symptoms of myocarditis. Most of these patients require hospital admission, so they get very sick. They require ICU admission. I'm sorry. So they get pretty sick. And then, there is a combination of BiPAP and high flow nasal cannula, mechanical ventilation. Some of them require, ECMO as well, and the majority of them do require some sort of vasopressor support. In terms of treatment, in New York, they've done a combination of steroids as well as IVIG, and then they've had 2 deaths as well in their 99 patients or so. If you look at other data from across the US, again, the likelihood of the SARS-CoV-2 PCR to be positive is higher if there are 4 or more systems that are involved, but then that's similar in for antibody testing as well. A lot of these patients also tend to have be in contact with somebody who is known to be COVID-19 positive. And then, like I said, similar to in New York, a lot of these patients, do require intensive care unit, meaning that they can get pretty sick. And a significant portion of those also require mechanical ventilation. So again, and across the US, we've had, a handful of deaths, but most of them do tend to recover. This again is the US experience that is outside of New York. There does seem to be, a lot of these patients, the majority of them actually do have some cardiac involvement, but that is as measured by either elevated troponin levels or elevated BNP levels. The level that we're looking at is, greater than 400 of the BNP. They do seem to, some of them have pericarditis, reduced ejection fraction as well, and then some of them, will have arrhythmias as well. And then if you look at the non-cardiovascular involvement, again, GI, as I said, GI involvement seems to be very common in this in this disease. And then you can have, other hematologic involvement that is usually either thrombocytopenia or lymphopenia. Rashes are there, and then, some sort of respiratory involvement as well. This is just looking at the lab tests that are generally abnormal in these patients. So you can have lymphopenia, low or neutrophilia, low platelet counts, elevated D-dimer, elevated fibrinogen, elevated liver enzymes. So just basically all of these markers of inflammation that, and they're usually markers of systemic inflammation. So it's not that as if there's inflammation in a particular body, organ system, but it's usually generalized inflammation. And at our institution, we have had about 12 kids so far with Miss C, and as you can see, they're pretty much all over the age group. We've had some older kids, we've had some younger kids. We've had one kid which was actually pretty interesting. This 10-year-old who came in with severe abdominal pain, and they did an abdominal CT on him, and the surgeons thought that he had appendicitis. And then once they removed the appendix, he was still very inflamed, continued to be febrile, had all these elevated inflammatory markers. So he was then referred to us for possible MIS-C. And that was really interesting because, maybe he didn't really even have appendicitis. It was just, this systemic inflammatory condition that resulted in this very severe abdominal pain. And and actually when they were doing the surgery, they noticed that not only was the appendix inflamed, but his entire small bowel looked just very inflamed. So we've had kids, and then a lot of these have had the ProBNBs have been in the 4,000 ranges. Some of them have been somewhat elevated. And then at our institution, we've sort of come up with this protocol or management strategy. So in patients who have severe MIS-C, these patients are always in our pediatric ICU. Those that have mild disease will obviously go to the floor. The older the typical age for these are about 9 to 10 years, and median is about 9 to 10 years for both of them. For clinical presentation of severe MIS-C, these patients tend to have fever, and the fever tends to be for a longer time. Their abdominal pain is more severe. They tend to have more hypotension and more sort of signs of shock, and they're plus minus on myocardial dysfunction. Those that have mild MIS-C, they have, they can also have persistent fever, and they also tend to have, tachycardia, tachypnea, abdominal pain, though it tends to be less severe. And then if they have myocardial dysfunction, it's usually, again, less severe. And then, the lab findings that we typically look for are thrombocytopenia or lymphopenia, and then we're looking for either a positive PCR test or a positive serology. When they are admitted, they all get an echo at the time of diagnosis, and so obviously the echo is part of the process to diagnose the disease. And then while they're hospitalized, they get twice weekly echocardiograms as well. For the more severe cases, we tend to start off with 10 milligram per kilogram of Solumedrol, and then we also give them IVIG. If the patient is having some fluid issues, we start off with 2 grams per kilogram, but we if they're having sort of fluid overload, then we sort of reduce that to 1 gram per kilogram. If they stabilize in the next 12 to 24 hours, then we reduce the Solumedrol to 2 milligrams per kilogram per day for 5 days. And then if the inflammatory sort of markers are coming down and the patient is doing well, then we sort of do an oral prednisone taper after that. If they are not doing well, then we basically give them additional Solumedrol. And we have not had any patients where we've had to give more than 2 to 3 days of the high dose Solumedrol. So they do tend to, seem to resolve. They do tend to respond to that. We tend to give them low dose aspirin unless our ICU doctors give them Lovenox for some reason. And then because these kids will present in something that looks like septic shock, we do blood cultures, we do all the regular stuff that we would do for any bacterial septic shock. So we do give them antibiotics in the beginning. And then we make sure that there's no, focus for like staph or strep infection or anything of that sort. So while all of that workup is done, these kids are on antibiotics, but that's only a rule out. And once the blood cultures come back negative, then the, antibiotics are not a part of this treatment as such. And then we have talked about using potentially, if despite the Solumedrol and the IVIG, if the patients don't get better, we have talked about potentially using things like anakinra or tocilizumab as biological response, but we haven't had to. We have not had to use any of those yet. In more mild disease, we start off with Solumedrol, just the lower dose Solumedrol, and then if they improve, then we basically switch them to a oral steroid and then taper that. If they worsen or don't get better, then we do give them IVIG as well. And then in terms of follow-up, we follow them up in our infectious disease clinic, and we do an echo at 2 weeks after they've been discharged from the hospital, and then again at 6 weeks, both for the severe and mild. And I will say in our experience, even those patients that have had, either myocardial dysfunction or aneurysms or, dilation of the coronary arteries, on the initial echoes, all of them have recovered all the echoes look normal on follow-up so far. So.
We have stopped.
Yeah, I'm sorry. If anybody has any questions.
Sorry, I was also having trouble with my Zoom. I think Zoom is not cooperating today. So thank you so much. I think you can stop sharing, Dr. Arshad. Very good. And thank you so much for this presentation. It's so interesting and enlightening. Makes me wonder about post-infectious syndrome in adults after the COVID infection. And I don't think that there have ever been any discussion on that. And we see a few of those in neurology with other viral infections. But there is, it will be interesting to see what kind of syndromes we'll see, like Guillain-Barré or other in adults after the COVID infections. So very, very interesting talk. Very well done. Thank you. Before we go on to questions, I will first start by having the panelists introduce themselves and make comments, and I can call on name one by one as it shows on my column here on the right side, and have you guys introduce. But what I would like to do for people to send me your questions either in the chat box or Q&A box. You can, it's preferable to ask questions related to the topic, but you can ask questions related to anything related to pediatrics, because we have so many pediatric experts here today that we've never had before. So it's a great opportunity. I'm seeing so many messages coming to me that people are having trouble logging into Zoom from Pakistan. It's just not seems to be working. We have quite a few people actually watching this session live on YouTube, which seems to be working easier than the Zoom over there. And I will try to take questions from YouTube too, or Facebook if I can, and also from WhatsApp. But I think it will be more useful for people to watch the recording later because of these trouble. So please send me your questions or raise your hand if you want to make any comment and want microphone, and we'll try to get to you as we go into discussion. So let me start by inviting our panelists today, going through this list I have. Let me start by inviting our president of APPNA, Professor Naheed Usmani, who's present here to introduce herself or make any comment about the topic today. Dr. Naheed, please go ahead.
Ji, Assalamu alaikum. Thank you so much, Danish and Mehreen, for a wonderfully comprehensive presentation. I was particularly interested in it because I'm a pediatric hematologist oncologist, and we follow a similar condition called HLH and mast cell activation syndrome that we see happening in children in response to different viral infection. Overall, it doesn't surprise me that we have a COVID-related mast cell activation syndrome. It was very important to recognize it early because it happens a few weeks after having had COVID infection. Also, I think a critical development was setting up a registry where all mast cell COVID-related multisystem inflammatory syndromes could be reported so that we have a national idea as to the prevalence of this condition. I found this webinar extremely informative. I think it's something we as pediatricians need to recognize and then to take appropriate measures. Treatment is simple, but supportive care could be quite challenging. Thank you very much, Danish, for letting me give my comments.
Thank you, Professor Naid. I knew you would like this topic because of your pediatrics background, and thank you for being here. Let me go on to invite Dr. Salman Majeed, who is a clinical assistant professor at Penn State Hershey Medical Center, adult, child, and adolescent psychiatrist. Dr. Majeed, please introduce yourself and make any comments related to pediatrics and COVID.
Thank you so much, Danish. I'm Dr. Salman Majeed, child and adolescent psychiatrist in Hershey, Pennsylvania. And on the topic of pediatric population, I think I deal with mostly what have the changes been at the time of coronavirus for the kids, how do we inform, and a few comments about the discussion has to happen with kids. It's already happening. School age kids already know because the schools are off. So the discussion is usually child-centered and their questions. If the news channels are covering 24/7 and are spreading more panic, more breaking news every single second, you don't want to have that constant cycle going on, at least when kids are around, because they are absorbing, even if they're not looking at the news channel, they're listening to it. And many times for anxious kids, there is chance of regression. And for the discussion, it should be developmentally appropriate, what questions they have, simple and honest, and not to instill more of the adult fears. The other important change that has happened for kids and parenting is because of the time that they are stuck in the home. If you're a parent and you're doing telehealth or working from home, particularly younger kids might come in your meetings and they might disrupt that. So for kids below 3 years of age with their separation anxiety, you might have been able to leave the home and comfort them when you come back. But now being in the home and not attending them could create distress. So usually the best approach is letting people you work with or even your patients or your colleagues, let them know that you have little kids. Sometimes they might come in. And I work in child and adolescent psychiatry as well as adult psychiatry. And my discussions are very confidential. So I use headphones to limit if there is discussion that I don't want them to listen. But I just let others know if they're walking around that they're around. And it is okay. I have a 3-year-old. My 6-year-old doesn't come in, but my 3-year-old does walk in at times. And if I push too hard, then it's going to backfire. There's going to be tantrum. So usually balancing that, looking at their developmental needs. And then the other thing is your relationship. So once you're done with the work, you do want to spend a lot of time with them because the screen time has increased for kids in general, and also looking at what they're watching. There are many free resources. So Khan Academy is one. Khan Academy is a free resource. So getting your kids to utilize that, they could learn as well. But also one last point, particularly for educated parents, that we are too much more inclined to lean towards their academic learning, that their social emotional learning or needs sometimes get missed because we have been trained heavily focused on the performance or how well we are doing. So we somehow unconsciously communicate that to our kids as well. So balancing that social, emotional needs as well as teaching them those skills is a key, and opening those conversations, treating them at their developmental level. I think that's the key message. Of course, I'm open to, if there is any questions, please write in the question answer area. Thank you so much.
Thank you so much, Dr. Salman. Let me move on and invite our next panelist, Dr. Nighat Mehdi, who is an associate professor of pediatrics in the pulmonology division in University of Oklahoma. Professor Dr. Nighat, please go ahead.
Yeah, Assalamu alaikum, Danish. Thank you for giving me the opportunity to join this important topic in pediatrics. As you know, we are in the South, so we have not seen the surge in children yet, but we've had a couple cases of same MIS in children, and they were suspected. I'm not sure if they were positive or not, but there have been cases. So since I'm a pulmonologist, I would just like to add that the differences in children who get COVID-related multisystem involvement is that these cases, parents have to, if somebody has COVID, the child is at risk, even if they are younger kids. An important fact is that these symptoms are being seen later on after 6 weeks or so. So I think that is the important message for the pediatricians, for parents, even if the kid was had mild symptoms to begin with, maybe watching them longer. And from lung standpoint, I think the most important is to remember that it's an immune-mediated kind of process. And the lungs have receptors for the angiotensin converting enzyme. So ACE into angiotensin 1 to 2, 80% of that is converted actively in the lungs. And COVID is a disease which occurs when the type 2 receptors are attacked by the virus. So differences in children and adults are there. So that is why children are getting less of lung involvement compared to the adults. So I think I just wanted to point out that, and also differences in cytokines and maybe genetically different, because some of these studies have shown still that Africans, Americans, and Hispanics, those children that had these multi-system systemic involvement, they were still higher in those kids too. And Mehreen can verify that for me too.
Thank you so much, Dr. Nighat. Appreciate your comments and being here. Let me move on and invite our next panelist, Dr. Samina Hijab, who is a medical director of pediatric critical care in Women and Children Hospital, St. Alexius in Illinois, USA. Dr. Samina, please go ahead.
Assalamu alaikum, everyone. Thank you so much for inviting me and being a part of this very interesting and informative webinar. I would like to say, we have seen this syndrome in a couple of patients, who have been admitted to our ICU here. And most of a couple of them, they presented like typical with the Kawasaki disease, all like a picture perfect kind of everything was, we found in them. And the first one was really very striking. A 6-year-old child, who came in, and we thought it was Kawasaki, but finally it turned out to be a COVID-19 multi-systemic inflammatory syndrome patient. Fortunately, he recovered and he went out, but he has been followed up with the cardiologist right now. There were some mild myocardial dysfunction which was going on. But anyhow, he really did well. We have seen also more patients. And very interestingly, what we are seeing here is about the psychiatric patients who are coming to us from different facilities or from home. Mainly 90% of those patients, they come to us from the facilities where they are living in Streamwood or here and there. And their presentation was mainly very mild. They were asymptomatic, I would say, but just like abdominal pain. And we have a policy to get them tested for COVID, because once we have decided they need to go in for inpatient behavioral health center, then we need to test them. And, it was very surprising information that they tested positive for COVID. So couple of patients we have admitted on pediatric floor, not to ICU, who tested positive. And fortunately, we had a zero mortality at our institution. Everyone recovered and went home. As we are expecting, and that's that is what regarding the surge, we are predicting most likely the coming fall is going to be really worse, because 30-40% of the patients usually they present with superimposed infections. So viral infections coming in with the COVID-19, that is where we are predicting our season is going to be really bad. So far, I can say, compared with the adult population, we haven't been like, admitting so many patients with COVID-19. And I think, in the pediatric world, there have been a lot of publications, literature has been published why the peds patients have not been so sick like adult population. So many theories. I don't know exactly, what the right answer is, but this is where we are.
Thank you so much, Dr. Samina. Appreciate for being here and your comments. As I move on to my next panelist, I want to remind you that I am keeping track of all the questions that are being put in the Q&A box. And I'm also trying to follow the chat box and the information from WhatsApp, Facebook, and YouTube, and through some help. So please keep your questions coming. You can also raise your hand if you want to make a verbal comment and would like to have the opportunity of getting a microphone. Let me move on and invite our next panelist, Dr. Muhammad Zishan, who is Assistant Professor of Psychiatry at Rutgers University, the State University of New Jersey in New Jersey. Dr. Zishan, please go ahead.
Thank you so much, Danish Bhai, for the opportunity. I think really great presentations, and I'm also a child psychiatrist, and what Salman Bhai, who is also a good friend and a good mentor for me, I think mentioned about using a developmentally appropriate language. I think it's very important. For example, if child is young, I think using language like safe, like we are staying home, we are wearing masks, we are not meeting family members, so that we can keep safe. So that's, I think, a good word, rather than explaining, corona can cause death, corona can cause this. And as Salman Bhai mentioned, there is already so much panic from the media. So try to limit, that screen time. The other thing I would like to highlight about the medication component, because so I'm doing some remote teaching in some villages for the past couple of weeks. And one thing that we are in Pakistan. So one thing that we are hearing a lot is that this misconception that even kids and adults who are sick, they are not going to doctors or pediatricians because they believe that the doctors are giving injections or vaccinations or medication to decrease the population, especially during coronavirus. So I think so increasing awareness, what we are trying to do, increasing awareness about the illness, physical or mental, and how like if anyone has any concern or question, rather than not going to the doctor, having those conversations with the doctors, what their concerns are. And third thing, because I have, I think Salman Bhai also mentioned on the parenting, just to think, kids are at home, schools are closed. So ideal parenting doesn't exist. I just want to say it out loud. Mistakes happen, child is angry and you are having difficulty, they are not going to school, you are trying your best, and so there may be a lot of time when, it's hard for parents, or it's hard for even pediatrician or doctor to understand what's going on. So just reminding yourself that, this is a tough time, and, and we all are learning as we are going, and trying to compensate. Like if you have done something wrong with your child, or if you have having difficulty understanding your child, so next day try to repair it, or try to understand, or try to improve it, what you think you have done wrong. The other last comment is about screen time. Definitely that have been increased significantly. So how to limit? I think it's good to have some clear goals. Goals could be that, kids, depending on the age level, 8 to 9 hours of sleep, the meal time, the homework time, and the family time. And then screen time can be, we can have that a child can earn a screen time after doing this activities. Thank you.
Thank you so much, Dr. Zishan, for being here and making your comments. I have the pleasure of having a co-chair of APPNA MERIT in lead for projects of dermatology, Dr. Babar Rao here. Dr. Babar is also leading a lot of efforts in telemedicine and is leading the projects in research development in APPNA MERIT. Let me invite for comments Dr. Babar Rao to introduce himself and make his comments. Dr. Babar.
Thank you, Danish. I am surprised that your energy never goes down. I don't know what kind of batteries do you have. You and Shahid keep going. So in reference to mast cell degranulation and then causing the reactions, I actually have an anecdotal report. On Friday night, one of my manager's mom had the worst urticaria ever. We went to ER, they put her on salomedrol, gave her 50 milligram of prednisone, sent home, but I kind of forced them to do a COVID while she was in ER. They thought I'm crazy, but anyway, she came home and prednisone 50 was not touching it. And then is next day and her COVID test came positive. But she has no fever, otherwise stable, so we didn't want her to go back to hospital. So I said, let's take a shot. So I said, let's do what we do in urticaria. So we put her on heavy doses of hydroxyzine, almost like 25 milligrams 3 times a day. She slept for a day and a half, and guess what? Woke up and stood up and started eating. So I think I was just relieving the itch. I didn't even have in mind I'm stabilizing or protecting mast cells, but that worked. So what previous speaker was talking, how to do that. I think in some cases, I am starting to add, and I'm suggesting, if otherwise okay, I think adding antihistamines to just put them to peace and relax may help with a lot of these symptoms. Also, my second comment is like, as previously when some child or some patient have urticaria, or they have some kind of viral rash, we say viral rash, you send home. But now we know for sure certain infections are causing certain rashes inside and outside the body. So my recommendation is, if you see a child or an adult who's having shingles for no reason, urticaria for no reasons, and some other COVID like, purple toes for no reason, I suggest basically testing them and isolating them and moving forward. Thank you.
Thank you, Professor Babar. Do you want to also plug in about your Merit research group and project there for people to join?
Yes. So basically, many of us are doing plenty of research in United States and other parts of the world, but we are organizing a group through Shahid, Nahid, our president, and Danish, where we want to see what is happening in research in Pakistan. Shahid has some statistics on them from a year ago. And then we want to pick some one little area to improve on that, either an institute or a project. So we're just getting the group together. We have many people. All of you, please send your interest to the Merit WhatsApp or email to Danish. And we're going to soon have a initial meeting, sort of a brainstorm meeting. How should we move forward in research in Pakistan? Thank you.
Thank you. And our email contact is appnamerit@gmail.com. So appnamerit@gmail.com. Please reach out to us for any questions or comments. Next, I have the pleasure of having someone here who I took the opportunity to invite into the panelists, Professor Amir Ahmed Malik. Professor Amir Ahmed Malik is the head of pediatrics at Quaid-e-Azam Medical College in Bahawalpur. And we had the pleasure of his company, so we thought we'll invite him for comments, see what issues he's seeing and facing and what comments he might have. Professor Amir, please go ahead.
Assalamu alaikum to everyone. So very nice webinar, very interesting. And I have few comments because I'm here in Bahawalpur, this is the south part of the Punjab in Pakistan. But as we see the cases of COVID, they were more in Lahore, Pindi, Gujranwala, Shekhupura, Upper Punjab, North Punjab. But in our area, the cases were not as they were in the Upper Punjab. But interestingly, as I'm looking the PICU services over here in our hospital, which is a tertiary care hospital, Bahawal Victoria Hospital. So for the last 1 to 2 weeks, we are seeing many cases, the children, the younger children, about 2, 3, 4, 5 years of age, who are having these multi-system involvement. And the X-ray, they are very typical, suggestive of COVID. But as Dr. Zishan was pointing out, the main problem, the very strange situation is this: the public is not ready to hear the name of the corona or COVID. So the serious patients which are admitted on oxygen and they can't be moved out, when we talk or discuss with them, we want to test for the COVID. So they take away their children and they run away, straight away. They refuse. So this is very complex situation which I'm observing here in Bahawalpur regarding the pediatric patient. That is quite dilemma. So misinformation has been there in the public in Pakistan about this poison injection the doctor they are giving to all. If you look how many doctors, senior doctor, junior doctor, they are going to be victim of this disease in Pakistan. So how can we open the eyes of these people about this? They are not ready to face the reality. Actually, this is very, very hard thing which I'm observing over here in Bahawalpur with reference to the pediatric patient. But with typical symptom, Miss C is quite on rise nowadays, which I'm looking here in my unit, in my hospital, and in the PICO. So the Dr. Danish, Dr. Zishan was very rightly pointing out this misconception. It has to be taken care of. Otherwise, the people, they leave the hospital and they don't allow us to touch the patient. They don't allow us even to take the samples. So this is very strange situation over here. And this Miss C is now coming in many patients clinically, which we are looking over here. Although we are very unlucky, we are unable to test them, but it is quite on rise. Thank you.
Thank you so much, Professor Amir. I think you touched on many, many important points and topics there. And while you were discussing, I think it will be useful and important to do a session on these misrepresentations and fears among the public in Pakistan. And I invite you and your team from Qaeda-Azam Bahawalpur to participate in a session doing this and maybe lead a session. So if you don't mind sharing your email or contact, we will be happy to set up with you a session specifically about fears and misperceptions in Pakistan about COVID-19.
Yes, yes. Why not? Why not? Inshallah, inshallah. I will be in touch with you. I will invite you, please.
Thank you so much. And to complete the list of experts that we have available for discussion before I go on to the Q&A, let me invite quickly Professor Noor Mahal Kabani, who is our lead in APPNA MERIT for work on critical care and on nursing development for her comments and introduction. Professor Kabani.
Thank you. I am Dr. Noor Mahal Kabani. I do not have a title of a professor, but thank you very much for that. but I am I just have a quick comment. First of all, Dr. Mehreen Arshad, thank you very much for an excellent presentation. And I have one comment on your comment about heparin versus low molecular weight heparin versus the IV heparin. So the comment I have is that low molecular weight heparin is actually very commonly used amongst the intensivists for the simple reason that it has turned out to be biologically available better, less monitoring at a low dose, and it is more predictable response. That is the reason. Otherwise, both drugs are used. And secondly, when we do have a patient with renal failure, then we use IV heparin. My pediatric ICU colleagues can sort of say that. I have one comment or one discussion that I would like to open up with our esteemed pediatric colleagues, and that is about the school openings, both here in the United States as well as in Pakistan, have a lot of concerns. I've heard from Dr. Rao, I've heard from Dr. Mehreen. The symptoms are so generic that how are we going to handle school openings and still continue the, the flattening the curve concept of when kids are back in school. So thank you.
Thank you so much, Dr. Kabani. So, we have few questions come in, and there have been few discussions in the past on some of the concerns. So I want to get some comments from our speaker and some of our panelists on these. But to get started with the Q&A, let me actually invite someone who has raised his hand to make a comment, Dr. Bilal Moeddin. Dr. Bilal, please go ahead.
Assalamu alaikum ji. This is Dr. Bilal Moeddin, all the way from Lahore, Pakistan.
Welcome.
I've been trying to get a chance to visit your site. I took the membership earlier, but somehow or the other, the protocols of the day and everything do not allow you to come in. And being a cardiologist and working at those who are familiar with Lahore, I'm heading the cardiology department of King Edward Medical University and Mayo Hospital. So we are sort of quite busy over there looking after our patients. Just to put a few matters into perspective, especially from the comment regarding the Bahawalpur and everyone else, my basic concept currently, the way I am looking after my patients, is that I explain to them the thrombogenicity part behind this disease. And now virtually each and every patient who comes into my cath lab, elective or emergency, of course, for emergency, it's just an immunoglobulin test that you may be able to do. But as far as for the electives are concerned, none of them come into my lab without getting a COVID analysis done, because you have to sit down with the family and explain to him. As I saw that a lot of psychiatrists are with you on board, and I think the old problem still persists, and the old desire of teaching is becoming even more important, which basically says that you need to sit down with your patients and have a one-to-one communication. The art of history taking has gradually been drifted away because of these new sets of investigations and the way that things have taken a turn. The grandfathers of our medicine, our Khwaja Sadiq, etc., they used to just simply sit down with the patient and, would have their development of a one-to-one relationship of honesty and trust. So all of this media information actually, which also has come in, probably and partially we were also responsible that we never were able to curtail it and control it. And then a lot of things which came into the notice of people, that is why we have ended up with a lot of this problem. So my request and recommendations as far as this is concerned is that the medical community and the media at large, we need to sort of get together and keep on informing. As far as this whole the thing about how the things are moving in this part of the world, you would be glad to know that when the pandemic in Lahore really hit hard, Mayo Hospital at a certain time was looking after more than 500 patients over there. As of yesterday, I understand we have just got about 50 patients. So things have really settled down over here. We have looked after a lot of patients. We have had our set of problems, but Almighty Allah subhanahu wa ta'ala has been extremely kind on us, and things have been quite good. But yes, a lot more needs to be done and a lot more needs to be understood. But of course,
sorry to cut you off there, but let me just quickly move on to some other questions and comments I would need. Let me first invite Dr. Mehreen Arshad, our speaker, to address some of these comments that have been made so far and questions raised, including some questions Q&A box. Dr. Mehreen, please go ahead.
So I'll So I'll just start looking. So one of, I think Dr. Mir had asked about, the inflammatory response. I'll come back to the school question because I think that's a long that's a long answer. But so let me get through some of these other ones first. So Dr. Mir had asked about the inflammatory response and the fact that it starts. Why are we calling it post-infection when a lot of these tests are positive? So one of the things, Dr. Mir, is because a lot of these patients have prior, if you get their history, they've had URI symptoms or COVID-like symptoms in the past, like a few weeks before, and then they may have tested positive at that time, or they may not have tested positive. And what we think happens is that in patients who have MIS-C have delayed clearance of the virus. So basically, they're not getting the virus, they're not getting the symptoms, the symptoms of MIS-C at the time that they are at the same time that they get the virus. They're getting the virus, and then the virus lasts for several weeks, and then they're getting this MIS-C symptoms after several weeks of being infected. So that's sort of the differentiator. But you're right, a lot of these kids are also positive for PCR, and so that part is a little confusing. But we think that a lot of these, that the actual infection with the virus happens several weeks before the symptoms of MIS-C. And then Dr. Abdul Sami asked about the role of immunization, specifically BCG. There is some thought that BCG for other non-COVID viruses, there are actually some studies that have shown that the BCG vaccine that children get basically has an impact on T cell maturation, and so improves the immunity against other viruses as well. We don't really know about COVID. It's sort of hard to know because fewer children get COVID. Some of them have BCG. We know, like in Spain, for example, parts of Spain, the BCG vaccine is still being given, and they also had a significant number of cases of COVID. So I think it's little. We're not 100% sure, but maybe the BCG vaccine has a role, maybe it doesn't. But I would say right now we're not really sure. Okay.
Dr. Mehreen, if you allow me, let me just take Dr. Sami, who's with us, to introduce himself and make his comments on the questions he was posting. Dr. Sami, please go ahead, unmute yourself.
Hello, I'm Dr. Abdul Sami and field epidemiologist from Balochistan, Pakistan. My question, which is answered, that here we have here something from people that the children immunized for BCG and polio, they are not affected. And another point is that here we have very less number of children who are brought here, and they have been tested. We have very little number of the children here who have COVID positive. Maybe one reason is that the parents are not willing to test their children for COVID. And here my question again from the experts, that what are the signs, symptoms, specifically in kids and children's about the COVID? Because we have seen very less number of children and kids here in Balochistan who are affected or are positive for COVID-19. Thanks.
Thank you, Dr. Sami. Dr. Mehreen, you want to take on that?
Yes. So right, absolutely. So the BCG vaccine I already answered. I'm not sure that we have the data for that. In terms of the signs and symptoms of COVID-19 in children, I think that is, it is hard to, because there aren't any specific signs and symptoms. If you take a child who has COVID and you take a child who has flu or RSV or para-influenza, any of the normal viral infections that happen in children, they usually all look the same. And majority of children do get mild symptoms. So it is actually very hard to sort of just based on symptoms to tell which patient has COVID, which child has COVID, and which child does not have COVID. And so yes, I mean, I think even in our system, like I said, we in our children's hospital we had 600 patients, 600 children that were positive, and the vast majority of them just had like a runny nose, cough. And the only reason that we were testing them was because one, because Chicago had, we had a huge outbreak of COVID. And then the other reason was because their parents or their daycare worker or somebody else, some other adult that they had come into contact was positive. So I think it just based on symptoms, on symptoms, it is very hard to tell, to differentiate COVID-19 from other normal, childhood viral illnesses.
Thank you, Dr. Mehdi. Do you want to make a comment on the school reopening?
Yeah. So this is a huge debate that's going on in the US, and I'm sure in Pakistan and other parts of the world as well. The problem with school opening is, we really do not have, I mean, I'll be completely honest. I think we have some data that suggests that, child to adult transmission doesn't happen as readily as adult to child or adult to adult. And that data is based on daycares that remained open in New York, for example, throughout the surge in the pandemic over there. Other places like Sweden, some in Switzerland, some in some other European countries that never shut down their schools or their daycares. But a lot of these, so there is some data that, the vast majority of times, the adults in those situations, in those daycares, in those schools, they're the ones who get infected first, and then the children get infected. Having said all of that, all that data is very sort of, one, it's limited to countries and places other than the New York experience. It's limited to countries that were able to get their numbers of COVID in the community under control. So, so it's very different than the US, for example, or Texas or Florida, where there's increasing numbers, where your ICUs are filled, and, we're talking about opening schools. The other thing is we don't really have good data because as soon as this pandemic hit, schools closed, so we don't really have any real life, large community-based studies to tell us what's going to happen when schools open. So the AAP, the American Academy of Pediatrics, has come out with guidelines and a couple of other guidelines as well that talk about, safe school opening. What does that look like? That basically looks like essentially universal masking. So teachers wear masks, students wear masks, any child above the age of 2 should be able to wear a mask, can safely wear a mask. Sometimes they don't keep their masks on. That's a different question. But I will tell you, even in our pediatric hospital, the kids, when we tell them to keep a mask on, they do keep a mask on. So I think there's a lot of, parental training involved in that. And then, there's things like, frequent hand cleaning, frequent sanitizing of surfaces, making sure that, kids are kept home. If they're sick, having online versions of school, so that if they are sick, they're not coming to school just so that, because they'll be missing school. So we need to do these sort of, and the other big thing is decreasing the size of the classes as well. So some school districts have talked about doing hybrid versions. So half the class comes to school at one point, the other half, works from home, those sort of things. Now, all of those are, I think they are, my personal opinion is that while all of those measures are great, the problem still remains that when you open schools in a community that is increasing rates of COVID-19, there are going to be adults that are going to that will come into the school system and children that are either pre-symptomatic or asymptomatic. So even if we say like everybody is, doing their job and, reporting symptoms, we know that pre-symptomatic and asymptomatic spread occurs. And so I personally think that it is, not a good idea to, jump to opening schools when you're in the midst of a pandemic and your ICUs are full and your hospitals are full. Now, having said that, the US is a big country, and there are many other countries in this world that have kept their numbers low. And I think, in those situations, school opening with all these precautions is probably okay. In Illinois, where we are, personally, I probably will send my kids to school, because we had a surge in Chicago in our state early on a few weeks ago, and since then our numbers have been coming down. We've had less than 4% positivity rate on our testing. So I think in those situations, and everybody wears a mask. There's no that's the other problem. A lot of states in the South and even in the North, sometimes they're against wearing masks because it's against their personal freedom and things like that. So if you're not gonna if people are not going to wear masks, none of that, it's just not going to work. So I think it's very it's dependent on the community, it's dependent on the school district, it's dependent on the local epidemiology, and all of that is written in the AAP guidelines. And so I think it's it's a very individualized approach that we need to take, and we need to be smart about that. Given the context, the school is very important for children. So those are my comments.
Danish, can I add one comment?
Please go ahead.
Yeah, I think definitely very valid comment from Dr. Mehreen. So now, we are talking about this spread of this viral illness, but as a psychiatrist, I just want to highlight that not only the virus is contagious, but also the stress and the fear. And I would say that if we have maybe, 200,000 people who are affected by COVID in a country, but way more than that, 10, 20, or 30% more than that people who might not be affected with the virus, but affected with the stress and fear. So when we are talking about opening school, when we are talking about, effect of COVID, I think we also want to make sure that we are also doing some measures to decrease this fear, spread of this fear, this stress from parents to kids, from teachers to kids, and from kids to other kids. Thank you.
Thank you, Dr. Zishan. And before I invite for closing of this session, if anyone else have any comments?
Yeah, Danish, I have a comment.
Ji, Dr. Nighat, please go ahead.
Yeah, Danish, I would like to say I'm a pediatric pulmonologist, and I've given this task of people who are very sick, including cystic fibrosis patients, patients who have severe asthma, who are on the biologics, and there are patients who have muscular dystrophy, Duchenne, and SMAs. So to me, one part of the population is the normal, healthy child, and the other part is the sick child. So I think it is important to remember, I think like I would appreciate, like Mehreen said, I agree with her. We all have to make our own decisions from state to state, because we are getting a surge right now. Every day we have 500 plus cases, 700, 800. So I think by end of July, when it's time is there, we have to make our decisions for our sicker population. Should they go to school or not? For the others, well kids, I think like others have said, they all possibly should go to school, and let's see how things go. But with the same thing that the schools should be good about taking temperatures or wearing masks and good hand washing. And if they can make them like 2 classes or something, or put some on telemedicine or online classes, that may be reasonable too. But for the cystic fibrosis or very severe asthmatic, we may have to just like phase it out, like phase 1, okay, all healthy children go there. Because every year, my September, October is really bad, because kids go back to school and a lot of viruses, a lot of illnesses, a lot of acute asthmatics come back to the clinic or to the hospital. So I think we should separate out healthy kids with no issues and kids who have underlying health issues, and then look at our own statistics wherever we live, how many cases we have. And then if kids are sicker, parents should be good about not sending them to school so they don't expose other kids. And same thing for daycares or schools, to send them back. So I think it will be very important and challenging for all of us. And I really do appreciate Mehreen giving a wonderful presentation and opening up this door for all of us to think about. And for the sanity of parents and patients, I would say opening school is important. I have moms who are going crazy trying to do online teaching and then having to work from home, or trying to make babysitting arrangements economically too. But again, if there is a big surge when they go back, then maybe we all have to reconsider. It's going to be a challenge.
Thank you so much, Dr. Nighat. Let me invite Dr. Shahid Rafiq to introduce himself and close the session for today. Dr. Shahid, please introduce yourself.
Yes, Assalamu alaikum. Thank you, Danish. I am very grateful for this webinar, all the participants, especially our speaker, Mehreen Arshad, who actually has been with us from the start when we started this webinar series on 3/31, so March 31, 2020. we started because the COVID obviously in America was peaking before it peaked in Pakistan. So Mehreen and others have been, coming again and again, almost daily. And at that time, it was 11 o'clock at night, Eastern Standard Time, which was late for sleeping. But all the team and COVID experts, both pediatric and adult, have done this marvelous job. I would say now it's more than 2 months or 2.5 months. And during Ramadan and after, we changed the timing, and now we are doing it every Saturday and Sunday. So Sunday time, 11 here and 8 o'clock in Pakistan is reserved for our general COVID topic, because COVID has gone so big that, like today we talked about pediatrics, then we have talked about psychosocial issues around this pandemic, and also supporting how well we can support the frontline healthcare workers. So that's the additional angles to COVID, and that's what the Sunday webinar is for. And I'm hoping that Dr. Rao, who's present here, is a professor and chair of dermatology in New Jersey, will take up dermatological aspect of COVID in coming Sundays, one of these Sundays. So with that, and Saturday we have actually 2 sessions, 2 webinars. One is for nursing education, because as you know, not only physicians are dealing with COVID in healthcare system, but nurses are also in the forefront and actually doing a wonderful job in Pakistan. But sometimes, as the need is so much, both physicians and especially nurses are thrown into the forefront without much knowledge or training or skill transfer. So to support those nurses, we have started an 8-week program, which runs every 10 o'clock. So yesterday was the first one. Every Saturday, 10 o'clock here, and it will be 7 o'clock in Pakistan. And then second Saturday webinar is for the ICU, intensive care specialist, supporting one institution at a time. And then others listen how actual patients are managed in a critically care environment. So the critical care team from US and Canada and England talk to a critical care team of an institution and discuss real-time cases. And that time will be 11:30 here and I think at 8:30 in Pakistan. So please take note of all these times and webinars. And the more we have attendees and participants, and we feel that what we are trying to say is reaching the intended physicians, nurses, healthcare workers in Pakistan, the more we feel satisfied and happy that, whatever time our speakers and panelists are being given, or they are putting it in, it is being utilized. So please tell your colleagues, your family, your co-workers to join us in all these 3 and register for these webinars. That way you get the email reminder and you click and you can join the webinar. So thank you everybody, panelists, speakers, attendees, and we'll see you next week. Thank you.
Thank you everyone. Allah Hafiz.
Thank you.
Thank you.
Thank you.